Hello, welcome back to Oral Surgery Journal Club. Today we have an interesting article I'd like to share. This article concerns implants and the famous all-on-4 implant design, where basically you could restore a full arch with just 4 implants. The paper was written by Dr. Jensen, and it was published in 2010. This paper was specifically about the maxilla, and he's got another paper which hopefully we'll review next week about the mandible. Now, this paper is not actually about all-on-4 per se. It's about the all-on-4 shelf, which, according to Dr. Ole Jensen, is a surgical tool which helps facilitate the all-on-4 prosthetic design. And we'll get into what the shelf is and all the advantages and why Dr. Ole Jensen is, advocating for it so strongly. He comes up with a whole bunch of advantages that enables the all-on-4 design. But before we got into the paper, I'd actually like to just take a quick step back, I guess in a background sense, go over the history of how we got to, this point, where the all-on-4 design comes from. And interestingly, there's actually been 3 scientific breakthroughs, in a sense, which we went from a conventional, bury the implant and wait to get to this all-on-4. So let's look at very briefly, just 3 other papers. Dr. Paul Schnittman is the first dentist credited with immediately loading the implants, and it's an interesting story. So Paul Schneiderman, back in 1990, he was looking at immediately loading implants, and the purpose of, back in the 90s, they were waiting 7 months up to a year for the implants to integrate, because the thought process was you needed to wait that long. And of course, cosmetically, that was very difficult for the patients to wait. So he came up with this idea that he was going to place too many implants. You could see, like, he would place 3 implants. Those were going to be immediately loaded. Then he would bury the other 4 or 5, depending on anatomical considerations of whatever he could fit. But the point was, he was going to immediately load some, bury the rest, and the immediately loaded ones, those were intended to fail. They thought they would have primary stability, but not more than that. They would never osteointegrate because they were functioning immediately, but it would allow the patient to have some kind of temporary prosthesis, and then 7 months later, the failed implants would be removed and the other implants would be uncovered. And interestingly, they found that even the immediately loaded implants, they integrated, and quite surprising, but according to, they stumbled upon this finding that, hey, we can immediately load implants and they would still integrate. And ever since then, Paul Schnittman, back in 1990, realized that we can immediately load. This was followed. Dennis Tarnow also gets some credit, because Paul Schnittman published specifically with mandible, and then Tarnow, I guess a few years later, published that the same could be expected. The same success about immediately loading implants could be expected even when it comes to the maxilla. So between Schnittman and Tarnow, we have established that, hey, implants could be immediately loaded. The second scientific breakthrough comes from Brandmark, where he's looking at how many implants do we need, right? Typically, we like to think of implant is like analogous to a root. So for every implant, for every tooth, for every crown, you should have 1 root, you should have 1 implant. But Brandmark actually was trying to advocate, no, the biomechanical design is quite different from roots, and we can put a whole prosthesis on just a few implants. And here in this paper, he compares 4 versus 6, and what he found was that there wasn't a significant difference. So method-wise, he put in as many implants as tolerated from an anatomical consideration. So if a patient could tolerate 6, he put 6. If they can only tolerate 4, 4. And then he looked at the survival, and he divided it up by the upper jaw and the lower jaw. And while there was a very small difference, it was not significant, right? So the success was maybe 93% when it came to 6 implants versus 85% 89% when it came to 4 implants. And so it was a marginal difference between 4 and 6. And his conclusion is, one can conclude that the number of implants 10 millimeters used for full arch reconstruction can be either 4 or 6. So the second breakthrough was, hey, 4 implants work. And then finally, the third breakthrough comes from Dr. Fortin, and I should also give credit to Bo Rangert, because his name comes up on all the papers, and he's not a dentist, he's actually a mechanical engineer. And so Dr. Fortin and Bo Rangert were the first ones to discover, hey, we don't have to place the implants vertically or axially, we can tilt the implants. And so he was doing it to avoid the sinus for the same reasons that we still do it to this day. And he showed that, hey, these implants, you can get a longer length, you can get osseointegration, they won't fail, they function from a biomechanical standpoint perfectly fine, and he gets credit with the first tilted implants. And so basically, between these three scientific breakthroughs, between Schnittman and Tarnow showing, hey, implants can be immediately loaded, Brandmark showing 4 implants was sufficient, and Fortin showing we could tilt the implants, if you put those 3 concepts together, what you end with is the all-on-4. Now, Ole Jensen is actually the founder of ClearChoice, which is, a franchise dental facility which popularized this procedure, but he's by no means the first to do all-on-4. I believe the credit for all-on-4 goes to a Portuguese dentist, Paulo Malo, but either way, Ole Jensen certainly deserves credit. He spent his whole he's famous for doing implants. He spent his life doing implants, and now he's founded ClearChoice, which, they have facilities across the country, and this is pretty much all they do. All right, so let's get back to the paper and look at what Ole Jensen's talking about. So I guess in the beginning, he's talking about this was quite novel, and it's counterintuitive to most of the things we think about. And that's the starting point. And you have to swallow that before you really can appreciate the whole design. So typically, we're accustomed to trying to graft as much as possible, right? If there's an atrophic maxilla, then the way we're accustomed to thinking is, okay, let's graft, let's get more bone, more implants, and contrary to that, there's this innovation that, hey, we don't have to actually load the implants, we can tilt the implants, and then we don't need a graft. And the advantage driving that push towards graftless, of course, would be the ability to immediately function, right? If you were going to graft the sites, then of course that would stage the implants and cause further delay. And from a patient standpoint, patients don't want to wait. So that's driving this push towards immediately loaded. So then I like how he phrases it here. The surgeon is faced with the challenge of removing failing teeth, trimming back bone, avoiding bone grafting procedures, inserting dental implants at angulations, placing the patient into immediately loaded provisional restorations, all of which are counterintuitive to traditional surgical management. And that's certainly true. All right. So let's jump into it. So what is the all-on-4, this novel technique? So the all-on-4 means, like those 3 things, you're going to put 4 implants, you're going to establish a full arch, and you're going to do it by tilting the implants which helps you avoid the maxillary sinus, and at the same time you can immediately load it. Okay. Now, in order to do that, Ole Jensen's going to say you need to do this shelf. The shelf means you're going to remove the alveolar bone, and by doing so, there's 10 advantages which will help facilitate the all-on-4, and he's going to get through all 10 of them one at a time. So by removing some bone, which again is hard to swallow because we're taught the more bone the better, but removing bone actually will help you. Why? It creates prosthetic restorative space, right? We know there needs to be a certain amount of space inter-arch. So that's one advantage. 2, it establishes a plane in terms of getting rid of a cant. You'll have a flat plane. Shelf width, okay, that makes sense, right? We know the bone tapers towards the alveolar crest, but if you remove the alveolar crest, you get to the basal bone is always wider. So you're going to have additional width, which means your implants could be wider. Fourth advantage, the shelf reduction approximates the piriform bone. So by getting rid of the alveolar bone, means you're closer to the piriform. So when your implants engage, where are they going to be engaging? They're going to be engaging in the most dense bone, which is going to be great for osseointegration, or even just for primary stability and for immediately loading. Additional benefits. They go all the way to 10. We keep going. So the shelf findings will help you figure out where you want to place your implants. We'll get to that with some pictures. It helps you establish the optimal sites. It helps you find secondary fallback sites. It helps you engage the palate, which is of course more dense. It helps you gain additional AP spread. So AP spread means the distance from the most anterior to the most posterior, and that's an important concept. We'll take a break for just a second just to appreciate that. So AP spread means if you have to put 4 implants and they're all in the anterior and none of the teeth are in the posterior, then when your prosthesis is a posterior, it's going to be a posterior cantilever. And if you can imagine like a seesaw, if all your implants are in the anterior and you have a bite load, and you're biting on the posterior, you're going to like seesaw. So obviously you don't want that. So the AP spread means what is the distance between the most anterior and the most posterior implant. And when it comes to all-on-4, we try to get about a centimeter of AP spread. So between the anterior and posterior implants, there should be a centimeter. And the reason for that is the cantilever can then go 2 times the AP spread. So if your AP spread is 10 millimeters, well then your cantilever can go up to 30 millimeters according to Brandmark. Some newer studies don't quite want to go 2 times the AP spread. Some people say only go 1.5 times the AP spread, but even so, your final prosthesis can be 25 millimeters. Just because your AP is only 10, you go 1.5 more than that, so you can get 25 of a roundhouse, which would probably be first molar to first molar. Okay, so it helps you get more AP spread. And then, of course, any bone that you take out, you don't have to throw in the garbage. You can then use that for grafting. And he talks about how you can graft if there's defects, whether from the extractions, if you're doing immediates and stuff like that. Okay. Then he gets into the 10 a little bit more detailed. I don't know if it's worth going into it right now. I'll just mention a couple of them. So I said inter-arch space. He says you need 22 millimeters, and sometimes they create this window so that you can see you have enough clearance for your prosthesis. That's number 1. Shelf width, of course, that makes sense, right? We explained it. It gets wider as you go up. The piriform rim is the most dense, and then so you're engaging. Look at these implants. You're engaging the piriform, which is great. Okay, then the optimal implant sites and angulation and the fallback sites. Here's a nice picture which helps appreciate that. So this is the design. So you remove all the alveolar bone up until you expose the sinus membrane, which is quite a lot of bone actually. Usually you have, even an atrophic mandible, even an atrophic maxilla, you usually have like 4 or 5 millimeters of alveolar bone before getting to the sinus. And if the patient has teeth and they're younger, well then you should have about 10 millimeters. So you're removing between 5 and 10 millimeters of bone so that you're getting pretty close to the sinus. He says in some cases you're going to expose the sinus right there and then, and that's how you know when your shelf reaches the sinus, well then you know where to place your implants because you see the sinus directly. But let's say you don't. Let's say you removed a lot of bone but you still didn't see the sinus. So then he says you create this S point, which means you just take a fissure burr and you poke a hole and you guess basically where you think the most anterior inferior aspect of the sinus is, and wherever that aspect is, so by poking the hole into the sinus, and if you miss you just do it again, who cares, these are all just little holes that you're making into the sinus. Once you find where your sinus wall is, then you know where your implant has to be just in front of it. And he says you measure the height, so where your S point is, you measure from the shelf to the S point, and that may be, let's say, 5 millimeters, and then you go 5 millimeters posterior and you put it on a 30-degree angle. So that's how you know how to put your posterior implant. Oh, and another point, he says you do the posterior implant first. In case that fails, you can always go a little bit in front of it, and then your anterior implant you do second, because that could always accommodate, in case your posterior implant needs to be changed, well, your anterior implant can accommodate that. But your posterior implant, obviously it's based on the sinus, so you do that first. All right, so this is what I was talking about, that you measure right in front of the sinus. All right, and that's pretty much it. Again, he's talking about the shelf in this paper, not necessarily all the little details about the all-in-4, but he explains how if you're going to do the shelf, it has all these advantages. And let's just conclude with this last sentence. After the surgeon can accept the idea of a non-axial implant placement, as well as reducing the number of implants, the all-on-4 shelf becomes a necessary tool to optimize what is a highly efficient, although counterintuitive, maxillary implant placement scheme. And I leave you with that. I thought this was a great paper. I hope you guys enjoyed it, and hopefully next week we'll talk about the mandible.